everyone to the Playing Games podcast. And today I have a very special guest, professor and researcher, Dr. Lisa Griffin. Dr. Griffin, how are you doing today?
Hi, good. Thank you.
Thank you for taking the time to join us on the podcast. And today's podcast is going to be a little different than usual. Dr. Griffin is actually going to present a PowerPoint on fatigue with some of my extra comments on it, if there are any. So why don't I just go ahead and pass the torch down to you and you could get the ball rolling.
Okay, thank you. Well, yeah, just stop. I'm happy to do it either way if you want to do question and answer, or if you want me to just go through the slides and then you can ask questions as they go.
Yeah, I think maybe just go through the slides and I'll probably just ask questions if there are any of like any popular trends or questions that people may have that are trending right now on social media. And maybe before, if you get started on the slide, if you could probably just introduce yourself a little bit, so for the viewers to know or get to know you a little better and your background.
Okay, so so I'm Lisa Griffin, and I am an associate professor at the University of Texas at Austin. I'm also editor-in-chief of the Translational Journal of the American College of Sports Medicine. And I have been studying neuromuscular control, physiology, and fatigue for many years. I did an undergrad in Canada in human kinetics at Western University, and then a master's and PhD in London, Ontario, in neuroscience in the same field of looking at how motor unit behavior during fatigue and neuromuscular mechanisms. And then I did a year postdoc at the University of Miami at the Miami Project to Cure Paralysis. And then after that, I went back to York University for another postdoc where we used transcranial magnetic stimulation. And then I've been at University of Texas in Austin since 2003, so for about 23 years now. I've received funding from NIH, Lone Star Paralysis Foundation, where else? Texas Department of Transportation for their stretch and flex programs. And I'm trying to think what else, but yeah, so I've been studying this for a lot of years. And I teach graduate and undergraduate classes in neuromuscular control and anatomy. So this area of studying neuromuscular fatigue isn't in textbooks yet, traditional textbooks. So when I teach neuromuscular control, I have to use a combination of textbooks. So I use traditional neuroscience textbooks, like Fundamental Neuroscience or Principles of Neuroscience, for how the brain controls muscle. So from like the neural pathways back and forth from the muscle. And then for the for muscle contraction, I use more physiology textbooks studying muscle contraction. And then putting those two together, there are a couple of textbooks out that put those together, but the leading edge of research in the field of neuromuscular aspects of fatigue and training really isn't in textbooks yet. So just to get started, the topic you invited me to talk on today was about fatigue. And so this first slide just defines the different components of fatigue. So when we think of neuromuscular fatigue, we think of central and peripheral mechanisms. We think of, decreases in descending drive from the brain, or we think of failure of, excitation, contraction, coupling within the muscle itself. But there are other aspects of fatigue that maybe become more important in, clinical populations or in work settings, like, this like mental fatigue or cognitive fatigue, which is different than physical fatigue. And then there's this more like a motivation, or there's also like an emotional kind of fatigue. So this idea of tiredness is different than, actual physical fatigue. And then when you look at the different types of training, there's a fatigue from, anaerobic versus aerobic mechanisms that differ. So during high loads or resistance power training is different than the fatigue of during endurance training. And then I thought this little picture was interesting. I just found it on the internet. But when we think about the other aspects of fatigue, tiredness, this is where lack of sleep or things like that, or you have people with chronic fatigue syndrome, that type of fatigue. You also have this, it's interesting that this emotional component, like you have these things like, caregiver fatigue or just fatigue doing one task. So I have my expertise is more in the physiological mechanisms of fatigue. Down here, highlighted in the red, the central and peripheral fatigue. But I just like to point out that these other areas of research are really important. And also I think what needs to be integrated here is response to pain. So just like people who are in constant pain, that can wear on them, and these small nerve endings can inhibit the central nervous system. And so some of this fatigue and tiredness, has to do with those small diameter afferents that affect both the central nervous system and the motor sensory system, as well as the cardiovascular system. So I think these different fields will eventually come together as we study the fields more, and there'll be more research that will help bring the other systems together.
Can I also add that, or from maybe you know a little bit about this? From what I read, I think different researchers define some of these or name these fatigues differently. For example, I think Roger Inoka calls an actual objective measure of fatigue fatigability, and then he calls mental fatigue just fatigue. Is that something right that people do sometimes?
Yeah. So I have a lot of respect for Roger Inoka and his contributions to the field over the years. So I have learned in being in this field for whatever, almost 30 years, that the terminology changes over time. So there's different, jargon. This field is full of jargon. You have terms like muscle memory, right? And that muscle memory implies that there's that neural component, to the muscle, or that word can be used differently, or neuromuscular facilitation. So I think it is really important to not for us to argue about the terminology, about which terms mean what, but that we are clear in our understanding during our discussions of what it is that we're talking about. So for example, if you define peripheral fatigue as only in the muscle, right? Like some people, this is how I define it, as that peripheral fatigue, I think of that as only like in the muscle fibers itself. But some people will include the spinal cord in their definition of peripheral fatigue. So they'll think of central fatigue as from the brain to the spinal cord, and then peripheral fatigue from the spinal cord to the muscle. When I talk about peripheral fatigue, I think of it as in the muscle and everything in the central nervous system as being central fatigue. So I think that the focus should be more on, learning how the body works, learning how, rather than arguing about what terms we want to use for what things. As long as we both understand what we're talking about, we don't have to, we don't have to, I think, create the language for the field, because that has changed. It changes constantly.
Yeah, that makes sense, especially with central nervous system fatigue, because I know that one could get a little hectic because when you talk about like motivation and tiredness. I mean, isn't that all part of the central nervous system? So you can kind of like have to elaborate what you mean or how you define central nervous system fatigue sometimes to other people.
Yeah, yeah. So when we're talking about exercise, we think of when we think of central fatigue, we're thinking of, that drive from the motor pathways to the motor neuron pools in the spinal cord and anything that affects that drive. So you may feel tired, or you may have just written like a big exam, but then you could go out and perform really well, And
Yeah.
so I think, the capacity of the central nervous system is something that, that is different than the capacity of the muscle itself.
Awesome.
And that is one thing that I want to point out, is I want to look for the picture, but when you think of, I want to jump to like something like this, like when you think about the muscle itself and you think about a single twitch inside the muscle, and you think about the maximal force capacity, the single twitch, that's dependent on, the muscle fibers itself. Inside the muscle, what's happening inside the muscle will determine how much force you can generate in a single twitch. But the summation of the twitches, the firing rates and the drive, from the brain to the spinal cord is what determines how these twitches summate. So you really have to think about them together. You have to think about the central nervous system and the peripheral nervous system together when you're talking about capacity for force generation.
Okay. And do you think you can kind of elaborate what you mean by a twitch, just in case if some people aren't too familiar with that term?
Yeah, sure. Sorry, I just clicked on. So a twitch, let me go back to the slide. A twitch is the force generated from one pulse, so from one action potential. Actually, no, you can use the word twitch in different ways too. So when you could use the word twitch to, it's always the response from one pulse. So you can use the word twitch to mean the force generated from a single muscle fiber, or you could use one supramaximal pulse going to the nerve to the whole muscle, and then you'll get a force response from the whole muscle, and then you could look at like a single twitch from an entire muscle. So a twitch means the force response to one pulse, but you can use that word differently depending if you're talking about a single fiber or a group of fibers from one motor unit or an entire muscle. So that word means force response to one action potential, but it can refer to a muscle fiber, a motor unit, or an entire muscle.
Perfect.
Okay, so if we go to the slides, so neuromuscular fatigue is traditionally defined as a reduction in maximal force output. It can also be defined as endurance capacity. So these two things don't always align. You may have heard of things like high frequency and low frequency fatigue may have some different mechanisms, or it can refer to coordination, like a decrease in accuracy or performance. So you may be able to sustain your endurance capacity or your maximal force output, but then you may have, disruption in the accuracy. So you can, depending on what your protocol is, you can define fatigue in different ways. Okay.
And do you know what you mean by low frequency and high frequency fatigue?
Yeah. So low frequency fatigue. So these are fatigue models that have been investigated. I want to say primarily in animal models where they use electrical stimulation to stimulate at different frequencies. So when they stimulate at high frequencies versus stimulate at low frequencies. So sometimes when they stimulate at low frequencies, and you look at the force frequency curves before and after fatigue, the force generated at the high frequencies are maintained, whereas the force generated at the low frequencies are not. So these can have different mechanisms, and always fatigue. The more you talk about it, when you get down to the muscle, the more it's just all about the excitation contraction coupling with the calcium kinetics. So again, there's this field is, even though it's fun to talk about and it's interesting, for athletic performance and just for being interested in the human body, it also affects many patient populations. So this is just like a list of ones that I could think of. So disuse right away, disuse at bed rest, everybody knows causes muscle atrophy right away. And this is and reduces endurance capacity. Anything like spinal cord injury, stroke, this is paralysis. These things that will affect the drive to the muscle. The same with multiple sclerosis. This will affect, and myasthenia gravis will affect the communication across the neuromuscular junction. Any damage to the brain, neuropathy. So this is damage to the peripheral nerves. So all of these conditions, these people are affected by fatigue. So this work, even though it's, it's fun as people who exercise and people who want to, get their best performance and with elite athletes, it also has many clinical implications. This figure is another one that I found on Google. I don't know who made it, but it's really cool. And we might be able to find out. Sorry. But because it has everything. So it has the drive from the cortex to the spinal cord. So yeah, so this artist did a really great job. So this is her motivation here, the desire. So I desire to move. So starting with the desire, in the it could be in the emotional centers and the limbic system, or in the frontal cortex. It could be this, I desire to move, and then so that sends excitation to the primary motor cortex, sends drive down the cortical spinal tract. There's also tracks from the brainstem pathways down to the lower motor neurons in the spinal cord that go out to the muscle. So out to the muscle itself, and then you've got the neuromuscular junction, and then you have the muscle fibers, and with the sarcomeres, and then the individual, actin, myosin, cross-bridge cycling. So you can look at, if you want to talk about fatigue, each one of these sites involved in generation of muscle force, could be sites, limiting sites for fatigue. It could be, the drive in the first place. How do you keep, with, repetitive tasks or with like performances that require, or even just high force contractions or long endurance performance, like just keeping the drive high is one of the first things. So you notice this in athletes or people who are not athletes, people who just start training, like that person who just starts to jog and they can run around the block and that's it on the first day. And then pretty soon by 3 weeks, they're running 3 miles, or the first time a guy goes to the gym, or a woman, some person goes to the gym, within a couple of months, they've increased their force, or within 3 weeks, they could increase their maximum force output by 30%. So this initial, is really more of like a learning process. This is just learning how to activate those motor programs. This initial training period is just learning how to, and then in elite athletes, they learn how to keep that drive high. So beginners learn how to just do it, and then really high level athletes learn how to keep that drive high, especially in the face of sensory feedback comes back up. So the pain from lactic acid buildup, or that you start actually getting inhibition at the brain and probably the spinal cord, where you have to overcome the inhibition. When the twitch forces start to drop, you have to increase, for submaximal contractions, you have to increase motor unit recruitment. You have to keep increasing the drive to maintain the same force output over time. So yeah, so this picture is a nice picture to talk about like any aspect of it. But we can go through these like throughout the next few slides. Let me keep going.
Yeah.
Okay, so this shows you summation of forces. So as you increase the firing rate, the twitches summate, and then you get to like a maximal tension. So this is where I also specialize in electrical stimulation protocols for people with and without paralysis. And so, so I've done a lot of research looking at different frequencies of stimulation. This is showing force, but so the frequencies aren't shown here, but typically motor units maximum fire rates of motor units will be, I don't know, between 35 and 50. Stimulation, well, for electrical stimulation to generate maximal force output is somewhere between like 50 and 80 to get maximal force output, hertz. And so, when you see super high frequencies being used in electrical stimulation, it's interesting, like the tens units, sometimes those are used more for stimulating blood flow or generating, heat. But this picture just shows the basic principles of force summation, which is important because sometimes when people think about generating force output, they think about the muscle, like, muscle hypertrophy, getting the muscle stronger. But a lot of it, and that's just getting this initial twitch higher, and actually getting maximal force output, this is coming from the brain, driving it at higher frequencies. That's getting the force up and stay up. That's all coming from the mind.
Do you think we learn to recruit more motor units the more we train? Right? Because I've heard that at least in vivo, we can't fully voluntarily recruit 100% of all of our motor units, maybe like really close to it. But I've heard in like scenarios of like life or death, that's when we fully recruit, like maximally recruit everything we have. Is that a real thing?
Well, that's that subtlety there about whether like a normal healthy person can actively recruit 95 or 100% of their units. I mean, that's just a little, fine area of like for argument there. The suggestion that in an emergency situation, the woman could lift up a car to save her child, like that came from like, newspapers in the 1950s. So this like, emergency reserve that only comes with, like stressful situations, that's really, I don't think that we have this untapped reserve that is very difficult to achieve. I think that with training, you can learn to recruit all your motor units pretty easily. It's just keeping them up, I think, is takes a lot of work. You can get, you can learn how to generate, ballistic contractions and learn how to recruit your units faster and get the force up. But yeah, it takes training to learn, but I don't think it's like there's a reserve there that's impossible to achieve.
Okay.
Okay, so this is just this definition of central and peripheral fatigue, as I define it as muscular fatigue. So central fatigue, I'm including both decreases in descending drive and decreases in spinal excitability. And then for muscle fatigue, which would affect the twitch force amplitudes, these can be affected by depletion of energy stores, slowing of excitation contraction coupling, or metabolic interference and calcium kinetics. So this is just showing each one of those in a little bit more detail. This is a study showing central fatigue and ECG performance before and after. Central fatigue, this is just starting to get into like, how can we measure these different things? Traditionally, central fatigue has been measured by electrical stimulation, where you could stimulate the peripheral nerve. So you have someone generating, I think the next slide shows this interpolated twitch technique. You may have seen this before. So if someone generates a maximum voluntary contraction and then you stimulate the peripheral nerve while they're contracting the muscle, if there's a superimposed twitch, it means that they haven't recruited all their motor units. And so again, depending on what, how deep you want to get into this, you can argue about the sensitivity of this measure. Some people use multiple pulses, like a double pulse, or 4 or 6 pulses to try and get this twitch. And then of course you've got potentiation of the twitch forces, and so you compare that to the amplitude after the contraction to get a percent activation. So that's traditionally how we measure percent activation. Like if we say someone's 95% activated, it's through this interpolated twitch technique. Okay. Also, central fatigue can be measured with transcranial magnetic stimulation, and here we put EMG electrodes on the muscle, and then we can measure the amplitude of the motor evoked potential to measure the excitability of the corticospinal tract and the spinal cord as well. So this will incorporate both. Some people will control for the excitability of the spinal cord by either stimulating the corticospinal tract directly, and others have used like H reflexes to measure the spinal cord excitability. I think the more popular way now, though, is to stimulate the corticospinal tract at the cervical level. Okay, so now moving into the muscle, the corticospinal tract will synapse onto motor neuron pools, and then each motor neuron will innervate multiple muscle fibers. Each muscle fiber is only innervated by one motor neuron. So here you can have, go to the next slide. This slide shows you the different places where you can stimulate the muscle. And then this slide shows all of the ways that the spinal cord can be affected. So if you have the corticospinal drive, shown here with the pink side, this would be upper motor neuron synapsing onto the lower motor neuron, or actually no, sorry, this is the motor neuron going to the muscle. Here's the lower motor neuron shown in black, and then this would be premotor area. This would be the corticospinal tract coming down to the lower motor neuron and the spinal cord. And so you can have pathways from the brain. You can have influences from the brain stem, which isn't shown on here. But you could also have this peripheral feedback. That's the main point of showing this picture. And again, this is just a picture that I like, that I found it to help explain it. So this shows you, you could have excitation from muscle spindles, but that excitation from muscle spindles is kind of always there. So when that reduces, that could lower force output. Like if the intrafusal muscle fibers fatigue along with the extrafusal muscle fibers, and you get a reduction in drive from the 1A afferents, then that could, cause a reduction in the excitability of the motor neuron pool. These small diameter afferents, the 3 and 4 afferents, could inhibit. And animal studies, it shows that they can inhibit the spinal level. There's been some argument about whether in humans they only affect these premotor areas. So that's why I've drawn this line up here as well to show that that these 3 and 4 afferents can inhibit, and that's usually that little round dot usually means inhibition, whereas this open sign means excitation. So there's pain signaling. Not only do you get the perception of pain, but you also get an inhibition in the premotor cortex or the premotor areas that will reduce drive. So now we have both the perception of pain and also the need to increase drive to the upper motor neuron, so that you can still maintain the level of force output just to the motor neuron pool. And this is even in the absence of what's happening at the level of the muscle itself. You could also have changes from the Golgi-Tendon organ pathway, or the recurrent inhibition. There's been less study on these things. Okay, so there's differences in what happens between maximal and submaximal contractions. So during maximal contractions, all the motor units are initially recruited, and then firing rates start to decrease after that. And so this could be from some adaptation of the motor neurons themselves, or from inhibition, from the small diameter, decrease in motivation, drive, and maybe even reduction from muscle spindles. During submaximal contractions, it's different. During submaximal contractions, you can maintain force or duration depending on the level of contraction. So this slide shows you single motor unit recording. This is in the triceps muscle during a sustained contraction. And here you see the motor unit firing. Initially, they start to slow down. This may be due to some initial twitch potentiation. You start to see, because potentiation occurs concurrently with fatigue processes. So in these early stages, you may see twitch potentiation, and then quickly you'll see fatigue. And that's triggered by recruitment of motor units. So even though muscles during submaximal contraction, EMG will be increasing because you're having to recruit more motor units to maintain the same force output as it goes on.
Can I ask here, what do we mean by the context of maximal and submaximal in terms of like a resistance training setting? Because let's say when somebody does high reps of 25 anything from like the higher rep ranges of like 10 reps and up versus doing 1 to 5, maybe 8 reps, would, let's say if you do a really heavy load for an 8 rep max, would that be like a maximal where you're lifting heavy, all your motor units are recruited, and then from that onset rep they begin to drop off? And then with the higher repetition, it's low motor units recruited first, and then as you get to like your failure point, you increase motor unit recruitment. Is that somewhat how it works?
Yeah, I think the way that you landed on that. So I was trying to find a nice picture to show you. But yeah, so if we go back to that motor unit picture, where did it go? When you think about recruitment, what slide was that? When you think about the muscle itself, okay, so if this is, say this is a low threshold motor unit, low threshold motor units, they will fire first, okay, because of Henneman's size principle. They have smaller diameters, and the dendritic trees are approximately equal size of the larger motor units, and so they get like kind of an equal amount of neurotransmitter And so with that charge, the lower threshold motor unit ones will fire first. And then, so when you're explaining it in like a dynamic exercise setting of, say, 25, if you start with something, you can do 25 reps, and then you end off, you can only do 5 reps. That's happening at the motor unit level. So when you start off, let's say you're only recruiting these lower threshold ones. And so as you're recruiting these lower threshold motor units, inside the muscle fibers, you're going to get some changes. Okay, so you're going to be producing a lot of ATP, so you're going to get some lactic acid buildup, and you're going to get some the lactic acid or the inorganic phosphate and hydrogen ions are going to disrupt calcium availability in the muscle fiber, and these twitch forces are going to start to drop. When the twitch forces of these motor units start to drop, then you have to recruit a higher threshold unit. So progressively over time, and then when these ones start to drop, then you'll have to recruit more. So progressively over time, if you keep doing the same exercise with the same force trajectory, you will follow Henneman's size principle and recruit motor units from low to high threshold, and eventually, you'll get them all. If you just keep going until you just can only do one last rep. And so when you get those really high threshold motor units, those are the ones that are going to hypertrophy the fastest, and that's how you get your high increase in gains. And so some people like to focus on the eccentric contraction because the muscle hypertrophy occurs from like small tears in the sarcolemma. So the eccentric contractions will kind of facilitate that process better, but you're still following the same Henneman size principle for muscle force produced with exactly the same kinematics. Now, this is an interesting piece of this, though, is that when we think about motor neuron pools, when we teach it, at the undergraduate level, we say, okay, one muscle has one motor neuron pool and it follows the size principle. But when you look at some of the research, there's, a few papers out there that start to show that motor units can be recruited differently for different actions. So when you have different postures, the motor neuron pool could redefine itself. So you could, let's say you start with your 25 reps and you end with one, you can't do any more, you can only do one. If you slightly modified your posture, like if you moved your wrist from one position to another, you might be able to get, like another 5 more reps out of it because your motor neuron pool would be reorganized for the different task.
That's interesting you bring that up, because I also wanted to mention about like the bilateral force deficit. So let's say if you're doing a bicep curl with both hands and then you fail, if you drop one load and you continue with one hand, people would often find that they can do, I would say, maybe an extra rep or so. Maybe to an untrained nervous system, maybe to a trained nervous system, it may not be that big of a difference, but to somebody who's probably untrained, maybe that bilateral deficit could facilitate an extra rep or so.
Yeah, I haven't read all of the literature. I've seen that literature go the other way as well, that if you train one side, the other side will get stronger. So that I don't know too much about. My early suspicions when I read those papers about what do they call it, cross education or something, is that I was suspicious that they weren't carefully controlling the other limb. When you start to get fatigued, you start to recruit everything. Like when you think, okay, I need more drive. I got to get those super high threshold motor units. Like everything, you can see it in your face. You know what I mean? And so the coaches are always telling athletes to relax muscles that they don't need to perform the task. like relax your face, relax your arms, relax your shoulders. Like they're always trying to get that kind of that neural drive or neural reserve to the muscles that they need, you know. So I think that when you say that you be stronger if you stop using both limbs, it just to me it sounds more like a focus issue, like being able to just focus, and that someone who you're right, someone who's highly trained that may not be as evident, but that's just my guess.
Okay.
Okay, so now at the level of peripheral, so that's my area of expertise is really at the motor unit level. And so, I mean, I know a little about this inside the muscle itself. So, but my research really most of the research done like inside muscle fibers is done on animals. So inside the muscle, we have once you get from the neuromuscular junction, um, and so that picture, there's the motor neuron goes to the sarcolemma, and there's a motor end plate, and then the action potential travels down the sarcolemma. And then this should be review, I'm thinking, for a lot of your viewers. It travels down the T-tubule, and it excites, there's some communication here. There's both a chemical and a mechanical communication between the T-tubule and the cytoplasmic reticulum, which contains the calcium. Calcium gets released, binds to the troponin, tropomyosin complex, and then activates allows for the binding of the myosin heads onto the actin to allow for crossover segment. So this picture shows you just how some of that interference can happen. That the integrinic phosphate or the lactic acid can interfere with calcium release and cross-bridge cycling, and ultimately reduce force output. I just kind of like these summary pictures. Other things to consider that happen inside the muscle are because the next thing after this, after we talk about fatigue, is training. What happens with training. So here, you've got blood flow going to the muscle, it's delivering oxygen. With training, you'll increase your vascularization, you'll increase your capillary beds. With training, you'll increase your stores within the muscle, you'll increase your number of metabolic enzymes, and even the number of mitochondria. So, but that's why these things will increase, because you need more. So these are limiting factors, and the more you train, the less they'll be limiting. You know what I mean? So that's what's happening inside the muscle. So this picture shows other things that you think about when you think about limits of performance. So you can think of blood flow to the muscle, oxygen capacity. This is where endurance athletes study, or researchers study VO2 max capacity for endurance, and these all relate to getting the oxygen and fuel sources into the muscle. So this is an entire field of study that is different from my field, but it's interesting when the fields overlap, especially for performance measures. So really, it's like three different fields when you think of controlling force output. You can think of the neuromuscular field, that's where I come in, and then you think of the animal researchers studying inside the muscle fibers, and some people do study that in humans. And then you have the cardiovascular and respiratory physiologists that study the blood flow and oxygen and fuel sources. And then, of course, you've got fields like nutrition. And then when we think about back to where we started with things like sleep or behavior patterns, motivation, mood, all of these desire to drive, like these things, that's like other fields of research. So there's multiple fields that get into, performance output. This is just a reason to these small diameter apparatus can affect. So these these are the pain fibers. So this can cause, these get activated from muscle damage or lactic acid, and they can cause pain and inhibit the motor system, but they can also have effects on the autonomic nervous system as well. Okay, and then, so just like we talked about with adaptations in the, mitochondria and vascularization, the nervous system can also adapt, that we were talking about earlier. You can learn to increase, motor unit recruitment. You can produce doublets or bursting. This is what tremor is. When you do, when you're exercising and you start that tremor feeling, so that's this EMG bursting. This is twitch forces trying to align together to get that force that you need. And so this is just an alignment of the motor unit synchronization, with just more like, technically synchronization is more the alignment of single motor units coming from like a common drive to motor neuron pulse, but EMG bursting is just how to get all motor units active together to increase the twitch force output. And then there's been some ideas over time talking about rotation of motor units or alternation. I suspect that this might, have to do with some small, modifications of kinetics. So here's an example of tremor. So that I'm not sure why it's blurry, but you maintain force, and then when you start you get EMG bursting and tremor. This picture here shows doublets. This is a single motor unit recording where we used fine wire electrodes inside the muscle, and we found that the number of doublets increased with fatigue. Surface EMG increases with fatigue. These are some old papers here showing rotation. It's an interesting idea and really hasn't been replicated very well. That, theoretically, if the rectus femoris alternated with the vastus lateralis and vastus medialis, you could maintain the same force vector and allow some resting. So there's some old papers that claim that there's some rotation going on between muscle fibers. This is something there hasn't been a ton of research in the field. I suspect that there may be some resting and rotation, but I think that there's more work that needs to be done.
What do you mean? Could you repeat that a little bit? When the rectus femoris alternated, what happened?
So this paper, there's a few terms if anybody wants to look it up. The term alternating muscle activation, synergistic muscle rotation. There's a few different words. Always in this field, there's different words to mean the same thing. But this was a study that claimed that the vastus lateralis and vastus medialis would rotate off with the rectus femoris during a fatigued state. So it's possible, now nobody's ever tested this, but it's possible that endurance athletes would learn how to, rotate, it would be subtle rotations where you wouldn't see changes in their kinematics that much, but they may have these subtle rotations across synergies that allow for brief resting periods. This is something that needs to be investigated further.
By rotation, do you mean like for the fibers to like align with the pulling force or anything like that, or?
The fibers themselves don't move. It would be the like trading off. But that's another word, trade-off. Like one would be active and the other would not be active, and then the others would be active.
Oh, okay.
And then another thing, this is more of like for your followers interested in physical therapy. Sometimes when you have synergistic muscles working together, you know, because most of what I've been talking about right now has just been in like a single muscle. But we all know that multiple muscles, I mean, there's, you know, multiple muscles that cross every joint, and they all work together. But if one of them is weak or more fatigable, it can affect what's happening in the joints. So this one is, everybody loves talking about a glute med or the weak glute med. You know, that's the solution for everything, is the clams. But here, this is showing that glute med could affect, you know, the biomechanics of the knee. So we do have to remember that we're working with a multi-segmental system, and that all of the muscles need to be, you can't just have, you know, one strong muscle and one weak muscle, because it'll affect the whole body. So over the years, you know, that I've been in this field, like even, you know, through my own exercising and stuff, I think the exercises that we perform now, you know, the more whole body functional exercises are a lot different than, you know, the isolating muscles that the bodybuilders used in the 80s. You know, I think that this working on, you know, multiple muscle groups and more functional exercises helps with maintaining like joint health. So I've shown examples here from the knee and the shoulder, where, you know, if you have like something like the infraspinatus muscle that's weak, you know, that's always the exercise for the shoulders, strengthening that infraspinatus muscle. So if that one is weak, fatigued, it could affect the, this is an area of argument too, whether or not there's actually movement of the human head that causes impingement. That's something that people argue over in the field. But my point is not so much about the clinical assessments. It's about making sure that all of the muscles serve the joint are producing the forces in the way that they need to produce them and have the same fatigue capacity. Because if people suspected that, you know, I think there's some like kind of, I don't know if it's missing, that if you fatigue the prime movers, then the rotator cuff or the joint stabilizers will become injured. But I think that idea of making sure that all of the muscles are doing the job and strong enough and have the fatigue resistance capacity to do the job is really something that needs to be considered in the field. After you look at, you know, what's happening inside one muscle, you need to look at what's happening with its synergists and antagonists and during the functional movement. So that's an area that needs to be studied. We need more work on how the areas work together, and also for performance and accuracy, and then for pathologies and clinical disorders. And that is my next slide. And yeah, sorry, my personal video lagged so much, but I'm glad I had these slides.
No, I think they were very insightful. I think one last question I'd like to ask is, well, before the last question, from what I did understand in one of the sections, as we fatigue with like submaximal contractions, we increase motor unit recruitment, but then as fatigue sets in, or let's say peripheral fatigue causes reductions in muscle force, so we recruit more motor units to balance out that reduction. But then we have like central fatigue. Do those motor units begin to like decline, or the firing rates begin to decline near the end of the set, which is why we fail, because obviously our nervous system can't sustain that recruitment anymore?
Yeah. So once you're at max, so now let's say if you started with a submaximal contraction and then you kept going, and you recruited all your motor units, and now you've got all your motor units recruited, you're basically at your maximal force capacity. So sometimes I had students ask me, can I still get stronger? Will my maximal force output get stronger if I only train at submaximal levels? And then I always say, yes, if you push it to the point where you can't do it anymore. Do you know what I mean?
Yeah.
So even though after you've done like 100 reps, if you're at your max, and even if the force looks low, you're still recruiting those same motor units as you would have if you were like and the force looked high. As long as you're recruiting those high threshold motor units, you're recruiting those muscle fibers.
Yeah, and with maximal level contractions, those motor units are initially recruited and then they just begin to drop off. But I don't think there's much peripheral inhibition going on in that, more central.
Okay, so the firing rate's slow. I'm not sure about when you say that the units drop off with the max. I know that the motor unit firing rate's slow. Yeah, the high threshold units can become recruited, but you can learn to keep that maximal force. That maximal force is hard to keep for like more than about like 5 seconds, it's hard to keep that force up. It starts to drop pretty quick. But yeah, how fast the de-recruitment occurs and how much this motor unit firing rates drop, that's something that can be, reduced with training. Okay, I'm sorry, what was your second point?
With like when you have like a maximal voluntary contraction, one wouldn't expect as much like peripheral mechanisms. They would think more central mechanisms. Versus like say a submaximal contraction of like heavy or light loads, where they would expect more metabolic disruptions.
Yeah, and that gets back to your early question about high frequency versus low frequency fatigue. Yeah.
Okay. And I mean, regarding with the peripheral mechanisms, I know you mentioned lactic acid. I know there's like a lot of talk with like lactate and lactic acid, and I've heard some back and forth saying that lactate can actually help buffer some of the peripheral inhibitions. I don't know if maybe you might know anything more on that, just because I hear a lot of contention with that in the field.
Oh, okay. Yeah, so there are a lot of chemicals that get released that can activate the pain fibers. So there's lactate and hydrogen ions, which together are called lactic acid. There's inorganic phosphate from ATP. There's bradykinin, arachidonic acid. There's like potassium ions. So there's a lot of chemicals in there that can activate those small diameter afferents. Okay. And so but when we're talking about calcium kinetics, there's evidence, the picture I showed inorganic phosphate and calcium and hydrogen ions. So the hydrogen ions, they have that positive charge, and so they can compete with the binding sites of the calcium because it's also positively charged. So I could see that if you had more lactate, right, that it could bind to more of the hydrogen and it could theoretically buffer it. Now, I am not a nutrition expert, and so I don't know what you're getting at. I mean, you kind of implied that people want to eat lactate. Is that where are you going with that?
No. It's more so like the lactate itself. Like from what I've heard, is that lactic acid doesn't really exist in the body. It's more lactate, but the lactate doesn't cause fatigue. It's like a buffer to fatigue, something like that. I can't recall it perfectly, but it was one of like the contentions that I've been hearing when it comes to fatigue.
Yeah, that just sounds more again like how we're using terminology, because the lactic acid refers to both the lactate and the hydrogen ions, and the
Okay.
hydrogen ions are causing the disruption of the calcium kinetics. And so if someone argues, well, lactate is actually a good thing, I mean, that could be true if it's keeping the hydrogen ions away from the calcium, receptors. So
Yeah, and I think that was it, because I think it's the accumulation of those hydrogen ions, which are very acidic, and that
right,
kind of dropped the pH, and then that
right.
could
But
probably.
but at the end of the day, I mean, you're still generating lactic acid, and so with the hydrogen ions come the lactate and the hydrogen ions accumulate together. So that's where I think like when you're like, in this day and age, we have so much information, and that's actually why I agreed to do this podcast with you, is because I agree that it's important to get good scientific information out to people, from people who research it, because I do think that if you're someone who's just curious and really wants to learn, and if you're not reading all of the papers on PubMed, you're at risk of that, there's that telephone phenomenon where you say something in somebody's ear and then somebody else says it. You're used to like twisting the truth, where someone says lactate is good, and then someone else may say, well, lactic acid is good. It doesn't cause fatigue. I think, and especially if we're not agreeing on the jargon, so I think that if somebody, that you have to go deep. Like if you really want to learn something, if you're really interested in something, that you have to, and if you're doing like lifestyle modifications based on scientific knowledge, one, you really have to trust, who you're listening to, and two is you have to trust, where those sources are coming from, because even the studies themselves, you can have one study show one thing and one studies show something else. And if a person is only referencing one side of the argument, you have to be careful of that as well. So I do respect the scientific process, and our publications, and I think that it's important. I think that we're slow. Like science is always goes behind the athletes and the coaches and the therapists. Like people are always trying to find the new best thing, and the scientists are always kind of following along behind to see if it's correct. Like everybody's doing this now, and then the scientists will follow by and say, is that really true? Is the science, by nature it's slow, but when you go back to building knowledge, and you have to always, when you're learning new information, it should rarely should it like with the vast body of knowledge that's been built over time. You know what I mean? Oh, like sometimes, yeah, you have a whole paradigm shift, but if you see something that contradicts, traditional science, I would be careful to make sure that, that your source is legit.
Yeah, absolutely. Well, thank you again, Dr. Griffin, for this very insightful lecture. I hope it opens the eyes of the viewers into more topics, and probably hopefully motivates them to look more into these things and maybe even helps them with their studies. So thank you again, Dr. Griffin, for your time. I hope you guys enjoyed this episode, and I'll see you on the next one.
Okay, thank you, Sam.